We'd like to welcome you to our series on ethics and medical legal issues in the practice of podiatric medicine and surgery. My name is Alan Jacobs, and with me is Dr. Jeffrey Shook. And this series of presentations is being brought to you in cooperation with Kent State College of Podiatric Medicine and Surgery and the Podiatry Insurance Company of America. This session will look at the issue of consent forms. Why teach, or why even be concerned about the issue of surgical ethics and consent forms if you are a student or a resident? Well, there are a number of reasons. One of which is the fact that much of podiatry involves surgery. And with surgery, we oftentimes are making decisions based upon literature that at times is not as rigorously tested as some areas of medicine. So there is somewhat of an underdetermination in scientific principles at times, and surgery involves both art as well as a science. As students and residents, you've already seen that new technologies are constantly being introduced into the profession. And these new technologies are being directed by companies that are for profit, so that labs and dinner lectures and presentations are not at all uncommon. And we have to always remember that while these new technologies may appear to be useful, our first priority always has to be our evaluation and care of that patient. We also have a world in which many of the students and residents will be going out and making decisions based upon not only what their perception of patient needs are going to be, but institutional and organizational demands, so that you will have restraints on what you can and cannot do placed upon you by insurance carriers, by groups that you may belong to, organizations that you may be employed by. So here's a typical example of a common problem in podiatry, and that would be hallux limitis. And as students and residents, you'll see those who are strong advocates, for example, of arthrodesis for the treatment of hallux limitis. You'll see others who are strong advocates for implant arthroplasty. You'll see variations advocated, such as resurfacing implants. And all of these may have applications under certain circumstances, but you will meet various individuals who are comfortable with a particular approach. So if we look at the lack of rigorous scientific data to support many of our decisions, let's look specifically at the subject of hallux limitis for a minute. If we look at grades of recommendation, we find that non-operative management has a B recommendation. Chilectomies have B recommendations for grade 1 and 2 hallux limitis, and we don't have any real vigorous data to support decision-making for grade 3. We have osteotomies of the proximal phalanx that can be done to dorsiflex that, and again, while there are those who will say they obtain wonderful results from procedures such as the Kessel-Bonney, we really, again, don't have vigorous literature to support its use. We have a variety of decompression and plantar flexury osteotomies that can be performed proximally or distally. And again, looking at the literature, we have no A or B level literature to demonstrate that, in fact, this is superior. One of the older procedures around is the Keller procedure. And interestingly, the Keller procedure, which is not commonly performed in this day and age, actually has good literature support as a B. We've seen a variety of interpositional arthroplasties that have been advocated in the profession. And here again, it's done so with very poor literature support. Arthrodesis does have a fairly substantial report with B level. Scholastic implants, again, commonly performed, commonly recommended, and yet we don't have strong, vigorous literature to support its use. Two-piece metal implants, generally not recommended. Hemiarthroplasties have been around both as polymeric and metallics, and here again, we see a literature recommendation no better than C. So my point is that when we consent patients and make our best decision for that patient and best choices, in the area of surgery, a lot comes down to art and experience rather than rigorous scientific data. We want to have residents and students graduate who are ethically and socially responsible, and we want to examine ethical problems and concerns in the profession because we want to prepare residents for future leadership position. So let's talk specifically about the topic for this discussion, which is that of consent. And there are a variety of consents that can be given for the performance of procedures. Don't think for a minute that this is not a very highly pursued, very highly examined issue. There are many, many textbooks and many textbook chapters devoted to the discussion of informed consent. So what exactly is an informed consent? As a student, as a resident, perhaps as a practitioner, what is the process itself? Well, number one is that it is a process. It is not a piece of paper. It is not a printed document. It is a process in which you, as a podiatric physician, disclose appropriate information to the patient relevant for their particular problem and for that particular patient so that a competent patient, a patient capable of making a decision, can make a voluntary choice to accept or refuse that treatment. So consent is much more than just getting a signature on a piece of paper. It means you've taken the time to look at that individual patient, their individual concerns and needs, and determine what information is appropriate for that individual to make a competent decision based upon that information that you've given them. Consent is important because it makes possible a range of conducts that would otherwise be wrongful. For example, consent oftentimes defines the difference between medical treatment versus battery. It defines the difference between an individual agreeing to have a new implant material or a new orthobiologic utilized or a new wound care dressing utilized on their foot or ankle versus using them as a human guinea pig. So consent is very, very important in a legal aspect as much as an ethical aspect. And in podiatry, we generally use consents in two situations. Obviously, the first is to receive therapy, whether that's an injection, whether it's a debridement, whether it is a total ankle replacement or something in between. And the other is the agreement of a person to participate in a research project. Now, the history of consents, briefly, is an interesting one. There has not always been universal agreement as to what a patient is or is not entitled to consent to. Hippocrates, for example, felt that it was the duty of the physician to withhold information from the patient, that the doctor always knew best, that the more information a patient had, perhaps the more difficult they would be to manage, and he advocated withholding information from patients. The French physician and surgeon Henri de Mondeville stated that what one should do is tell every patient that they were guaranteed a cure, and that you only honored requests for information from the patient so long as answering that request would not interfere with those therapies that you wish to pursue. The famous American Revolutionary War physician, Benjamin Rush, was the first to advocate sharing information with patients regarding their disease and their treatment. However, he was adamant that patients must always remain totally obedient to that physician and that information should not be volunteered if it would result in less than obedient behavior by that patient. The English surgeon Thomas Percival noted that it was okay to provide patients with information. However, if it was the physician's decision that the doctor would be better served by lying or withholding information, that it would be allowable to do so. The modern concept of consent forms really started with the American surgeon Worthington Hooker, who first took the position that it was unfair to lie or withhold information from patients. What don't we want as an informed consent? Not every surgical procedure has a great outcome. Not every patient is happy. there can be complications, there can be procedure failures, there can be sequela to patients. And what we don't want is that patient's memory to look back and see the doctor as is depicted here, as a gotcha, and that perhaps they had been sold or talked into something that they really ought not to have pursued because there was lack of full disclosure. And typically, a written consent form does tend to legally override a later denial by the patient that they were unaware of certain circumstances. However, this does not apply if there has been misrepresentation. For example, telling a patient that they could undergo an arthrodesis of their great toe joint and they'll be wearing high heels and dancing in 10 days. This would obviously be difficult to support as an informed consent decision. Conversely, we also want to remember that just because you have a written consent does not prevent the patient from later stating that they were in fact unaware of a variety of details that could have impacted their decision, and had they known about these details, they would not have signed that document. But a written document, a written consent form, is a very powerful, powerful document to have in court without question. So what is needed for a legitimate informed consent, whether it is written or oral or implied? And two things. Number one is the patient should have a knowledge of relevant facts, not every fact that's ever been published, but relevant facts to their particular situation, and they must have adequate reasoning faculties. The patient must have the capability of understanding what is being discussed. And you see listed here most of the general considerations. They have to have some degree of intellectual maturity, emotional maturity. They can't be under duress so that it's difficult, for example, other than urgent or emergency situations, to argue successful informed consent when a patient's intoxicated, if they suffer from dementia, and so on. So you do want to look and ensure that that patient does in fact have the capability of understanding that consent form. Informed consent is one of the 4 basic principles of ethics that are advocated by Beauchamp and Childress. And those 4 basic principles are listed here. And the first is respect for patient autonomy. The second is the principle of beneficence. The third is the principle of non-malfeasance. And the last, the principle of justice. So what do we mean when we talk about respect for autonomy? And that's the patient's ability to make choices based on their individual beliefs and choices. We may disagree as a physician as to what we perceive would be best for that patient. If the patient argues they wish to have a therapy other than that which we are recommending, and you certainly have the option of not proceeding with therapy that you feel would be harmful or ineffective for a patient. But at all times, we must allow a patient to participate actively in that decision-making for consent to therapy, whether it's fusion of an ankle joint, fusion of a hallux interphalangeal joint, or anything in between. And in order to do that, as part of our respect for autonomy, again, we must provide adequate information to the patient to support their decision-making. The principle of beneficence is simple. We always want to do what's best for the patient. We always want to act in the patient's best interest. That is the first thing that we must always do as podiatric physicians. And non-malfeasance. We want to do as much as we can under all circumstances not to cause net harm to a patient. So autonomy requires that that patient have autonomy of thought, intention, and action. And that means the decision-making process must be free of coercion and free of coaxing. And this at times can be difficult because we have a bias. We've decided that a particular patient might be best served with a particular therapy. And we may inadvertently bias that patient and not meaning to do so. Or we may see situations where an individual has a relationship with a corporate entity or some commercial entity and wants to coax or coerce that patient into pursuing a particular therapy for reasons other than what's best for that patient. But an informed decision by the patient must be free of this coaxing or coercion, and the patient should understand the potential risks and benefits that are reasonable to discuss. For example, it's not unreasonable to talk about a high non-union rate in doing an ankle fusion in a patient who's a heavy smoker, perhaps is diabetic, perhaps is nutritionally deficient. More and more, we're also seeing calls to talk about likelihood of success. And if we have established known complication rates and failure rates for certain procedures, for example, removal of an interdigital neuroma, for example, non-union from a Lapidus procedure, if that data is available, it is useful to present that data to the patient to let them know you have an 8 to 12% failure rate for fusion of, say, a Lapidus procedure. You have an 18% failure rate following excision of a Morton's neuroma, when that data is available. So respect for autonomy involves, number one, informed consent. We have a competent individual to assess that data. You present information that is appropriate for that particular clinical circumstances. It involves always telling the truth. Autonomy also involves consent for the involvement of students, residents, and fellows. Patients have a right to know if someone other than their attending will be participating in the procedure, perhaps performing the procedure, and they are given the choice to agree to that or not to agree to that. It also involves confidentiality and, again, respect for the patient request. We may feel, for example, that an arthrodesis of a great toe joint is the best procedure. The patient, for whatever reason, is adamant that they do not want to have a fusion done. And if an alternative procedure, such as an implant arthroplasty, is acceptable and not felt to be harmful to that patient, then we have an obligation to consider that patient's request. Now, how far do we go with informed consent? How much choice do we give a particular patient? And when do we need informed consent? Certainly this nurse doesn't likely need a written consent to give this patient, for example, a sponge bath. Well, the answer is very simple. All interventions, particularly interventions that are invasive, require some type of consent by the patient. Not necessarily written, but some meaningful discussion. So not every action that we take involves a written consent. So what are the elements? Again, there are three basic elements. Number one, disclosure, sufficient information to make a decision for that particular patient. And while we're doing that, we need to look at that patient, speak with that patient, and evaluate their understanding of what we discussed. We don't want patients coming back to us later on and saying, well, you never explained it to me that way. I really didn't understand this. I didn't understand I needed to be in a cast. I didn't understand I needed to be in an external fixator for 3 months. I didn't understand that I would have something implanted in my toe to keep it straight. So we have an obligation not only to disclose relevant information, but to evaluate that patient and make sure they have an understanding, or family members also have an understanding of what we're proposing. It may be a Charcot joint problem wherein the patient's at risk for amputation of their limb, and they need to understand that this may occur even with our best efforts. They may have a diabetic ulcer with osteomyelitis, and here again, that patient needs to understand that that therapy may not be successful, even though everything is done correctly, all labs were evaluated properly, all techniques were properly applied, not all these procedures will succeed. So again, the second component, capacity. Does that patient and or their family understand the information so that they are able to make a reasonable judgment? And lastly, again, respect for autonomy, that we have that patient making a decision that was truly made freely without coercion or coaxing, without manipulation. And this is absolutely important. And it's important, again, to try to remove that bias from what we feel is best for that patient. So it involves an appreciation of the facts, an understanding of the facts by that patient, an understanding of the implications. If I fuse that great toe joint, it's not going to bend again. If I fuse your talonavicular joint, you're going to lose 70% of the motion in your hind foot. Let me show you how this works. To see this in and out, well, you're going to lose that. You'll still have up and down. And understanding potential consequences. If we do a bunionectomy, there may be some loss of power in that great toe. You may develop transfer metatarsalgia. There may be a scar that you're not particularly happy with. And it's important that we get the sense that the patient truly understands what we're discussing. There are also basic or simple consents that occur day to day. It's not necessarily written, where the patient is told what you intend to do, and you give them basic information, and the patient agrees. They accept the procedure. For example, you may have had a patient that had a phenol and alcohol toenail correction 2 weeks ago, and now they return to the office to have their other foot corrected. They're familiar with the procedure, they've gone through the procedure, but again, we will re-review that with them and get their consent to proceed. Or a consent may be implied. For example, a patient's being treated by you for plantar fasciitis, and you've told the patient if the pain continues, make an appointment, and we'll go ahead and inject that heel. And they return to the office specifically for the purpose of having an injection and say, doctor, my pain's just not getting all that better. Why don't we go ahead and inject today? You still want to discuss the injection. You still want to discuss potential things that can happen with an injection, and you still want to explain basic necessary elements. Well, the next question as a student or resident would be simple. Well, how much information is enough? Do I discuss complications that can occur with a 0.5% incident? Do I discuss things like avascular necrosis after a metatarsal osteotomy when we know the incidence is extremely low? Do I discuss the possibility of biocorrosion of an implant when we know this, again, is very, very uncommon? Where do we draw that line as to what represents adequate information? And there are 3 basic standards that are typically cited. The first is the reasonable physician standard, and that is, what would a typical doctor tell a patient about the procedure? The reasonable physician standard generally has been cited as less than adequate because doctors tend to be in a hurry. We tend not to spend as much time as perhaps we should in certain circumstances. We tend to maybe go through things too quickly. And oftentimes the reasonable physician standard has been criticized for that reason. Oftentimes we see quoted the reasonable patient standard, and that's an important one, I believe. And that is, what would a typical patient need to know? What would a typical patient want to know about the procedure? For example, if you're doing an ingrown toenail procedure and you're doing, say, a phenol correction, well, they would want to know about the possibility of regrowth of the ingrown toenail, the possibility of a chemical burn or contact allergy to the phenol, perhaps a cosmetically displeasing result with spicule formation, the possibility of an infection. So these are things that you would expect the average person would want to know so that they would be giving you informed consent agreement to proceed. I understand this can happen. And then there's the subjective standard, which personally I adhere to, but that doesn't make it right or wrong. And that's, what would this particular patient want to know? Because everyone is different. Everyone has different needs. Everyone has different expectations. And as you sit there and work with a patient, you may sense that there are certain things that are more important to them than others. For example, if you had a professional soccer player and they had a devastating complication following a first MPJ procedure, this would have greater significance for that particular individual than someone who's 75, sedentary, not involved in much physical activity. So we need sometimes to look at an individual and say, what does this particular person need to know? Because at times certain complications or sequela or procedure failures will be much more impactful in some individuals than the same procedure is someone else. So we typically see the reasonable person standard, and that's what would that individual need to know under those circumstances? What's reasonable for that particular patient? So it's neither deficient nor excessive in detail, but it's tailored to that individual's own situation. If we're doing work in a diabetic patient with some degree of vascular disease, then they need to know that the risks of limb loss or partial foot amputation, infection, vascular dysfunction, these things are much more likely to occur than an 18-year-old healthy, non-diabetic, taking no medications, undergoing the same procedure. So let's look at something like a Lapidus procedure. You know, the severity of a complication after a Lapidus procedure, such as painful swelling and non-union, is much more devastating in an active runner or a competition ballroom dancer than someone who's, again, relatively physically less active. Let me give you an example from my own practice. I had a mid-60s woman, a widow, whose entire life was competition ballroom dancing. And 3-4 hours a day, every day, she's in high heels, doing competition ballroom dancing. This was the most important thing to her in her life. It was her entire being. She developed some metatarsalgia and had injections performed of a filler to provide cushioning under the ball of her foot to relieve some metatarsal pain. Unfortunately, she developed a horrible allergic reaction to the filler. There was no way to successfully treat this. She had been sent to various medical schools, universities. No one was able to help her, and it destroyed her life because it destroyed her competition ballroom dancing. So here is something that was no fault of the treating doctor. She had metatarsalgia. She was injected with the material, but the consequences of that particular reaction were devastating to that individual. So sometimes you have to stand back and look at that person in front of you and say, what are the potential impacts of complications, procedure failure, or sequela for a particular patient, and alter the consent so that they are clear about this. In today's world, there are practical issues that arise also. In a perfect world, we would spend a great deal of time getting to know our patients, understanding what they're all about, and constructing a consent for that individual. Well, that takes time, and our current healthcare system does not value or reimburse you for time spent with the patient. So the question really is, in obtaining a consent form, do you really know that patient in front of you? Do you really have a relationship with that patient? And the obvious question, how therefore can we be respectful and responsive in constructing a consent form or consent discussion when we don't really know that patient in front of us? And this is something that you're going to have to learn to deal with. This is one reason that it's probably wise at times not to schedule surgeries the first time a patient comes into your office, even though they say, I'm here because I have this terrible bunion and I want to have it fixed. And sometimes it's good to have an initial long discussion with that patient and tell them, you know what, I want you to go home. I want you to think about everything we discussed. I want you to make a list of questions. I want you to come back with that, and I want you to think about everything. We're going to have another discussion, because it may be that you've misread that patient, and perhaps their expectations are more than you possibly could deliver. So getting to know the patient is helpful. And these are common examples. Take hammer toe surgery. Not every hammer toe surgery is successful. Some toes remain swollen. There may be bothersome scars. There may be lack of purchase. There may be recurrent deformities. Look at the oral medications that we prescribe. They have potential adverse sequelae. They can have side effects. And it's important that patients agree to take a medicine understanding the potential side effects that can occur. One of the things that I do, for example, is I tell the patients, when you go to the pharmacy and pick up your prescription, you're going to get some printed material. It's going to tell you all about the medicine and potential side effects. I want you to read that, familiarize yourself with it, and call me or call your primary care physician if you have any concerns or you have any questions. Bunion surgery. bunion surgery is usually tremendously successful. However, recurrences can occur, incomplete corrections can occur, delayed or non-unions can occur, stiffness can occur, difficulty wearing shoes can occur, persistent swelling can occur. Patients need to know that these are possibilities. Injections of therapeutic agents. Some therapeutic agents that we inject, such as, say, bleomycin for the treatment of warts, or even corticosteroids and local anesthesia for the treatment of plantar fasciitis, can have significant side effects. The injection of sclerosing agents for the treatment of nerve problems. Here again, we need to inform the patient and document in our notes that we have informed the patient of these potential complications. Things like hindfoot arthritis, or arthrodesis rather, can be associated with accelerated arthritis of adjacent joints. Here again, patients need to know these things. So the process in looking at alternatives, benefits, potential harms and risks can be rather complicated. Now, what about urgent changes in a consent? You're in the operating room and you realize that something in addition needs to be done, something that has not been consented for. Should you go ahead and do what is appropriate? Well, generally consent forms, as you may well know, do have a clause in them that allows the surgeon to do whatever's necessary if there are unintended circumstances that are discovered. So your decision to do something that was unplanned and non-consented depends on your judgment as to what's the severity of the problem, what is the urgency that that problem needs to be addressed. But when you vary from that consent form, you want to make sure the patient is informed and you want to be prepared to defend that decision. So that if, for example, you change an operative procedure, make sure that your dictated note and or any written notes indicate the findings you had at surgery, the reason that you felt that the original surgery had to be modified or abandoned, and therefore you made the decision in the patient's best interest to proceed in a certain manner because of some problem. For example, you may discover a large intraosseous cystic lesion that forces you to modify your osteotomy that you were planning to perform. Perhaps you had to vary your fixation because the patient turned out to be unexpectedly osteopenic. Perhaps the soft tissues were of much poorer quality that you had anticipated. Perhaps there was an abscess discovered that again was unanticipated. So some procedures are clearly urgent, some procedures are emergencies. Make sure that the patient is informed of this afterwards. Make sure that your notes give a thorough discussion as to what was discovered, what was encountered, and why it is that you felt you needed to change the procedure. You also have an obligation to discuss complications. And what is a complication? And oftentimes we confuse procedure failure and sequela with complication. A complication is any undesirable, unintended, direct result of surgery which is going to affect the patient, which would not have occurred if the patient had gone as well as could reasonably be hoped. However, let us say a patient has a hallux limitus and you perform a chilectomy, and unfortunately post-operatively there's still limited motion. That is not a complication. That is failure of the procedure to have corrected the problem. And this does not imply malpractice, and it does not imply poor judgment by the podiatric physician. Some procedures fail. Some people see us with plantar fasciitis. We put them on a stretching program. We give them injections. We give them pills. We give them whatever therapies are required, and they still have a painful heel that requires surgery. That is not a complication. That is procedure failure, and that can happen. And then there are sequelae. Certain procedures result in certain problems. For example, if we do a subtalar joint arthroeresis, there will be limited motion of that subtalar joint. That is a sequela of that procedure. If we do a calcaneal osteotomy, say for example a posterior translational calcaneal osteotomy. We have limited motion of the subtalar joint following that procedure. That is not a complication. It is a sequela of the procedure. So complications are undesirable, unintended, direct results of surgery, which would not have occurred if the surgery went as perfectly as we hoped. Now, Kent State and PICA are producing this series of educational tapes primarily directed at students and residents. And this is an area that is difficult to discuss but important. Patients should be told the extent of participation of students and residents in their care. You have to remember that the patient presented to an attending's office for treatment by that attending. And experienced surgeons are known to have lower complication rates than inexperienced surgeons. And when you make a decision to allow a resident to do surgery in place of the attending, and the patient has not agreed to that, you have made the priority, not the patient's wishes, but the training of that resident. You're saying, I believe the training of this individual takes priority to the desire of the patient who wanted me to do this procedure. But ethics applies here also. I mean, do we have an obligation to allow residents and students to participate in care? And the answer is yes, we do. And that's the principle of beneficence, the second of the four basic principles of ethics. Because we can't have people leaving residency programs never having performed surgery before. We have to protect the public because these are individuals who are going out into society and are now going to practice. So beneficence involves the training of students and residents and fellows so that they can now provide good care, quality care, competent care to future patients. However, patients have a right to agree to this. They should be told that with your permission, this resident or student or fellow will be participating in the procedure, will be performing part of this procedure under my supervision, because the patient has the autonomous principle to agree not to do that or agree not to. This is the position of the American Medical Association. And again, they're very clear. Patients are entitled to choose their own physician. And that includes accepting or refusing an intervention to be performed by a substitute. Think of yourself being in that position as a patient. You've gone to see a particular doctor, maybe they have a good reputation, there's a reason you selected that doctor, you want that doctor doing that procedure. And you want to have the right to agree or not agree to allowing others to participate. And you have an ethical obligation to ask that patient if they will agree to that. Because not telling a patient a resident will be participating, or a student or fellow, and then allowing them to do so is a form of deception by omission of information. Looking at the American Medical Association principles of informed consent, again, it's more than a written document. It is a process. It's a process of communication, speaking, understanding, verbal and nonverbal communication between the patient and the doctor. And it should be carried out by you, not a delegated representative. You should sit down, you should be discussing the matter with the patient, you should be answering their questions. What should be included? Well, according to the American Medical Association, the diagnosis if it's known, the proposed treatment, the risks of the proposed treatment, reasonable alternatives regardless of cost. Now, for example, it may be that the patient requires orthotics and says, well, I can't afford orthotics, or a particular medication, and the patient says, I can't afford that medication. This is a secondary issue. The patient should be made aware that these alternatives are available, whether it is practical for that patient or not, whether they can afford it or not, and the risks and benefits of alternative treatment, and the risks and benefits of no treatment. For example, I will tell my patients who have a bunion, for example, you're not going to die of a bunion. You don't have to have a bunion fixed. If it hurts you enough, if it's interfering with your activities of daily living, we can discuss fixing this, but you have the option of getting wider shoes or wearing pads or doing nothing. You also need to allow the opportunity for patients to ask questions so that they are comfortable, that they understand what's going to be done, whether it's a medication or an injection or a surgical procedure, that you, again, have had the opportunity to evaluate that patient's response to your discussion and whether they indeed have an understanding. I think it's good practice to document in the progress note your discussion with the patient, so that in addition to a written consent form, I will dictate in my progress note that day much of the discussion that we had, and I will highlight the most important potential complications that could occur, that I personally discuss this with the patient. Because if a patient later challenges you with regard to the content of that discussion, not only do I have a written document, but I've also got my progress note that says we most certainly did have a discussion, and I specifically discussed with you these particular complications. This is probably one of the most important things that you can do to ensure third parties that indeed you did have a significant, important, and useful discussion regarding informed consent. How do I improve the process? How can you improve the process? Well, number one, create time for informed consent. Bring the patient back. If you don't feel that they have an understanding, if you don't feel that satisfied that that informed consent was complete, bring them back and make time for a separate informed consent discussion. Simplify the language. Patients may not understand the word transpositional osteotomy. They may not understand the word arthrodesis subtalar joint, but they do understand we're going to take the ankle bone and the heel bone and remove that joint and stick these bones together so that they don't move again to correct your deformity or limit your deformity or reduce the amount of pain you're having. So simplify the language. Allow reasonable time for patient questions. Again, very important, look at that patient, assess that patient, and make sure they understand what you have been discussing. And lastly, try to understand the patient, because we live in a world where large numbers of patients are being run through offices very, very rapidly, and it may lead to a misunderstanding by you as to what the patient's goals and desires are. So this is not what we want for informed consent, as we saw in the movie Cool Hand Luke, but this is a true informed consent. You are providing reasonable information, and the patient demonstrates that they have a full understanding of that material. With this, I thank you for sharing this session with us, and Dr. Jeffrey Shook and I will now be following this up with a discussion to cover further points.